Good morning. Hope everybody's doing well. So we'll go ahead and call the meeting to order and welcome everybody, members and guests. And if you're speaking or talking during the meeting, feel free to introduce yourself. We're recording the meeting and as well for minutes, so I appreciate you doing that. I'd like to move on to looking at the minutes. Those were sent out by Gabby, and we'll motion or entertain a motion for acceptance of the meeting minutes from October 6, 2023.
Motion to approve.
Thank you, Dr.
It's
Register.
Alicia.
Is there a second?
Hey, it's Kelly. I'll second it.
Thank you. Any additions or corrections as presented? I've looked over and did not see anything glaring, but I was not there. All right. Any opposition to the motion? All right, hearing none, we'll say that the minutes have been approved. Period. I'll move on to Liz for the GTC updates.
Thank you, Dr. Patterson. Good morning. And good morning, everyone. Some really exciting updates for you this morning. You may recall that Dr. Ashley presented on we had put together a trauma system stabilization plan for requesting additional 61 million. And I'm happy to say that, although I can't promise for this session, but that request is making its way down the lane, and so far has been heard by Senator Watson, who chairs the Senate Health and Human Services Committee, Representative Cooper, who chairs the House Public Health Committee. We've presented in front of the governor's policy folks, and next week, if you guys can mute your line in the background, I know a lot of people are just joining now. That would be helpful. Thanks. And then next week on Wednesday, we are presenting to Representative Matt Hatchett, who's the chair over the big House side Appropriations Committee, and then the Lieutenant Governor, and then also on the same day presenting in front of the full Senate Health and Human Services Committee. So we're getting a lot of really great press time for that. So again, no guarantees for this session, and we didn't get in until sort of right on the heels of the session starting. So at least we're laying a good foundation for next year, just in case this isn't able to be funded. We recognize that 61 million is kind of a huge ask to sort of throw in there. But you never know. We could even get a partial payment this year, but ideally, we'd love to get an additional 61 million every year. And if you remember from the presentation, that raises that would raise your trauma center readiness funding to about a level of 50% for the level 1s, 2s, and 3s, and 100% for the level 4s. And because the readiness cost data that we have for the level 4s is so sparse, we want to try to do the best we can for level 4s based on the data that we do have. So I know that survey was a little bit painful, but to be honest, it's such a huge driver of these types of requests that we'll probably have to repeat that so we can make sure we're capturing your costs adequately. So that's kind of the big news. The other thing that's sort of gaining some traction, and there will definitely be a bill on this later. In case you don't know, the legislative session opened just a couple weeks ago, the second Monday in January, and we'll go till the end of March. So this is sort of a really busy time, and we're going to keep track. Gabby and I have a software that looks at anything that comes through that has trauma in it. So we'll stay apprised on that. But over the fall, there was a Senate study committee on rural healthcare provider recruitment, and we were invited to present at that. And Senator Bo Hatchett from up in the Habersham area actually led that committee, and out of that came a recommendation for something that I know will be music to everyone on this call's ears. Is challenges with EMS transportation, specifically inter-facility transportation. So John Chapman, who's Senator Bo Hatchett's one of his top aides, we've had a lot of conversations with him about what would a pilot project look like. And we're tapping into some of our commission EMS members for those initial calls. And now we're moving that further to broaden that stakeholder group on that call. So I think what they want to do is figure out what something like this might cost, and then kind of assign a dollar figure to it and run it through either attached to that bill, because the study committee recommendations will go through for them to pass. It just means that it gives a little bit more attention. And then potentially if there's some, again, an ask, like let's say we want to add additional ambulances or something. And I know right now that seems like pie in the sky because, you can put up all the trucks you want, but can you actually staff them? So lots and lots of details to work out. But I think overall, it's just really encouraging that two really good things are kind of making their way through. And at least they heard it loud and clear. And the information that it's consistent with the information that I've heard, meeting with the GHA Rural Committee. Most of the time, folks are saying that they can get acceptance. It's just getting the patient out of the building that seems to be like it's a challenge. And we know there's work to do on both ends, but certainly want to get patients to where they need to go. So those are the two main updates legislatively. And just one other thing I wanted to mention, because as you all know, with the Gray Book, the American College of Surgeons Gray Book criteria, that's the optimal resources document. I'm sure you all are familiar with it. I know it's not addressing level 3s right now, or level 4s, excuse me. There is a fix in process for that, but just like everything with the ACS, it's a little bit of a glacial pace. So stand by, that will be fixed. But one of the requirements in there that's caused a little bit of heartburn, particularly a little challenging for 3s and for 4s. I anticipate that this is probably going to be the same requirement for 4s when they update the book, but you have to have a certified coder in your program. One person. Now, for many of you on this call, you only have one coder in your building because maybe your volume is not high enough to necessitate having additional coders. So that person who enters data in your registry has to be certified, and that certification is based on the LIIM. That's the sort of diagnosis coding, if you will, for lack of a better term. It's the rules that we use to enter, and it's what gives you that ISS score. So in response to that, and of course, it's very expensive to have the course to be able to do that. It's about $750 a person. We're going to fund a coding course, and Kelly, help me out with this, because I think the date, if I'm correct, is February 29th and March 1st for that.
Yes, you're right.
Thank you. And we're going to do it right smack dab in the middle of the state at the Georgia Public Safety Training Center. And it is going to be 2 days. So yes, I know somebody's going to have to spend the night. And I know that people like to do things virtually, but for preparation for taking the exam, we get to have 2 or more, depending on how many people we get signed up, instructors in person at the course, plus your registrar is working with other folks in their state. So it's almost instant gratification. They can ask questions and get the questions answered right away. The instructors are available for, after course comments and questions and things like that. So that course will be on the 08 coding. And the reason for that is, even though we're moving to AIS 15 in 2025, and I say that for the ACS is doing that. They're the ones that kind of set the rules about what version you use in your software. And I know all this is very much in the weeds and detailed, but it's important because I just want to make sure everybody's set up for success with that certification. So I'm going to announce this on the administrator's call on Monday, because I'm just concerned. I don't want there to be pushback. Oh, I got to send somebody, for 2 days. Well, you probably need to send them. You could, because it's in the middle of the state, it's probably feasible to get there in the morning. It probably will necessitate one overnight, but it's a $750 course that you're not having to pay for. And you got to have the certification. It's better than, dragging it out over several months virtually. You're distracted and you're really not getting the information that you need. So I'm just trying to break the ice a little bit and just we're doing it in person. So please look out for that. Gabby may have already sent, if we haven't already sent the save the date, we're just finalizing the contract with the AAAM, and we will send the save the date shortly. And the next commission meeting is actually going to be in Madison, and that is February 16th, I believe. It is the 15th, sorry, in Madison. And as always, all the details on all of our meetings, etc., are on the website under the events section. So I'll stop there, Dr. Patterson. That's a lot of information. Happy to take any questions. And thank you all for being on the call.
Hey,
Thanks,
Liz,
Liz.
can
Oh,
you
sorry,
repeat?
go ahead.
Yeah, just repeat the coder dates.
Kelly, sorry, I know you said that and I didn't, I think it's February 29th and March 1st. That's a Thursday and Friday.
Yes, that's right. I'm going to put it in the chat, Liz.
Oh, thank you. Thank you. And it will be at the Georgia Public Safety Training Center in Forsyth, which is pretty much as smack dab in the middle of the state as it gets. So there's lots of chain hotels like right off of 75 there. So not too expensive. So again, $750 a person. We're paying the entire thing. So we do have a list of folks who facilities who need a certified coder. Many of you already have a certified coder. If we don't have a certified coder, you're not going to pass your ACS verification for level 3s. That's coming up next for you guys. So we will, we have to give first priority to you, but please don't miss this opportunity.
So, hey, Liz,
Yeah.
I think Dr. Patterson had to step away. So
I'm actually back,
I'm gonna-
Alicia.
Oh, okay, never mind. Well, whichever.
No, that's fine. I wish I'd heard Liz's update completely, so I'm gonna have to go back and listen to the recording.
I'll give you a private update, Dr.
Oh, thank you.
Patterson.
Thank you.
I
Okay.
know you guys are having a
Um,
day this morning. It's all
Yes,
good.
we are. Anything else, Liz, you need to talk about?
No, we're good. Unless I think somebody asked me to
So-
repeat a date, but unless anybody else has any questions, as always, just contact me offline if you
Okay.
have any questions.
Great.
Thanks.
So then we'll move on to old business, and I'm trying to look through the list. Is Courtney on the line?
Yes, sir. I'm here. Can you hear
Hey,
me?
Courtney. Good morning. Take it
Good
away.
morning. So on the March pause, we have finished all the preliminary courses. I met this week, I believe, with Glenda Grant and their gentleman, John, who is their videographer. So the plan is right at the moment, and I want to talk to several folks one-on-one to make sure that it works with them, is for our presenters to go to Mercer and do the presentation, the discussions there at Mercer, and they have the ability to insert slides and that sort of thing. John is very talented. He would prefer to do it at Mercer, but we will talk to the folks who are doing the presentations to make sure that they have time to break loose and go there. The other piece that we need to be working on, and I'll again talk to those folks, is how we break those sessions down. I think the easy way is, you're looking at the March, maybe one session for each letter of the acronym. Pause could probably be one session. I am talking to Dr. Ashley and Liz and some others, talked to Damian Scott at my shop and some of our staff about doing something that may or may not be interjected into the actual course, but to do an overview of the trauma system and why the trauma and what makes up the trauma system, a brief description of the different levels of the centers and what their capabilities can be, should be, the importance of immediate transportation, and I'm hoping that Damian can explain to the administrators of these hospitals why it's important the hospital and to the care of the patients in their community. So that's on board. We would like to do those things in February and be done with them at the end of February. So that's an interesting time frame. I don't know about calendars and schedules, but I'll be talking to everybody first of next week. So some of y'all expect a call from me. And that's pretty much my update. I'll answer any questions you got.
Okay, Courtney, thank you. Anybody, any questions for Courtney at this point? All right. We'll hopefully try to give you a further update with some concrete things done by our next meeting. Move on to action planning for the Pennsylvania Trauma System Foundation consult visits for the level 4s and the ACS system consult for rural focus review that we had last year. I'll open up the discussion for any further of this. I think right now, one of the things everybody needs to realize that March pause is actually one of the things on the action plan. So we are doing several things related to the action plan, and several things have been divvied up under other committees and other organizations in the state. So any other comments that anybody has?
Dr. Patterson, it's Liz, and I gave the group an update on that Senate study committee on rural healthcare provider, and something that came out of that I think is also going to address this, which is the EMS transportation issue, like getting the patients out. I know Kelly related one of your sort of nightmare stories in your facility. Sure. About trying to get a patient out and, it taking over 12 hours. And so we want to try to address that. And I know, there were a lot of things sort of talked about. Realistically, this is going to be another, we got to unpack this slowly. We didn't sort of get to where we are rapidly. And so some of the solutions are going to take some time. But I think between the targeted education and, trying to address the transportation by attaching onto another bill, because that rural healthcare provider recruitment, the findings of that are going to move through, and their recommendations are going to be approved. And right now they're just working with us on what a price tag would be to, do a pilot project. So I think that could provide some much needed relief. And unfortunately, it may not relieve all of you, because obviously it's a pilot and we could only do it in certain areas to start. But at least if we start collecting data and show these things do or do not work, if something is showing promise, then, rural is getting so much attention that I can't imagine they wouldn't continue it, but we'll just need to make sure we have good data. So.
Sure. Okay. Thank you, Liz. I can't stress enough that rural is getting a lot of attention, and ultimately want to continue to strike while the iron is hot, so to speak. Any other comments on the ACS system consult review and the PTSF consult visits? Okay, I'll turn it over to Alicia to talk about the rural and non-trauma center resources and demographic survey that's going on.
There you go. Trying to unmute my phone. Basically, if everyone has access to their email, you can go back to the date of our last meeting, October 6th, where Liz emailed that survey out to everyone. It's pretty good. I think it's, Liz, have there been any additions or edits to those questions? And is everyone familiar with the survey? Like, has everyone seen the questions? Has everyone seen the survey?
I got some feedback from folks, and thank you for those who took the time to send some feedback. I think someone was going to talk.
Hey, Liz, I don't know. Did it come from, who did the survey come from?
I think Gabby maybe sent it out. Maybe I did.
It was you, Liz, maybe?
Yeah.
It was either you or myself.
But it's been a minute. It's been a minute, and we can send it back out because there have been some updates to it. I would say it's you know, it's grown a little bit more robust, and we partnered with the Mercer, the folks at Mercer Rural Health Innovation Center, and you know, they're good with the survey science piece. You know, what things can we group and what makes sense? Because last thing we want to do is make this something that takes 30 minutes or longer, because then people aren't going to do it. So, and thankfully, and I think Nita Ham is on the call. She's been really pivotal in helping us, you know, get to the root of some of the questions, and you know, again, do it in a way that keeps it easy and pretty brief for folks to be able to get the answers. And she's got a lot of the contacts for all of you, not just in the trauma system, but folks who maybe aren't participating in the trauma system, but are key hospitals, rural hospitals, that we just want to know, what level of resources do you have? Like, what, you know, what's your ED staffing? Do you have, you know, board certified ED docs, or are you, you know, do you have access to emergency release blood? You know, things like that. And then, so we have added quite a bit more content to it, but I can't remember if they've sent us back the edits, because I believe we just had a meeting last week, if my mind is working correctly. And so once we get their final, they've, you know, created it in sort of a live environment with a link and then an associated Word document. So they were going to kind of just clean up a little bit of the formatting, because our brains were sort of working overtime and we got a little scattered in it. And they're just great at the organizational piece to it. So Courtney, do you know if they sent us the finished product?
They have not. So we probably this afternoon or Monday we probably ought to call them, because they were at the point, I think, that pretty close to jumping off point, and we waiting also from GIMSA. We had a two-prong approach there. GIMSA was going to give us a written report of what they got from the EMS world in their 10 town hall meetings across the state. So we were going to try to put those two documents together and see if we couldn't glean some information from both of them.
Do you think it would be possible to have the final version ready by the next GTC meeting in February?
Yeah, I think we you know, we had anticipated sending this out a lot sooner, and when you guys got it last, we were under a false impression that we thought it was pretty finalized. And you know, sometimes you know, we don't know what we don't know. So when we take it to the folks who are really good at it, you know, they say, well, you know, this could be a little bit better. And then you know, our work with Dr. Eileen Bolger from Washington, who's a former COT chair, we enlisted her help in it too. So she really helped sort of tease out some of those resource availability kind of questions. So yeah, our hope is that we will have it, you know, sooner rather than later. The next commission meeting is, you know, just a month away. So certainly by then, but whenever it's finalized, we'll send it out to this group just for your eyes. I think for those of you who gave me feedback, you'll find that the questions that you brought up were adequately addressed in the updates.
Good, awesome, thank you. Does anybody else have any questions on the survey before we move on? Okay, thank you.
All right. Thank you, Alicia. Appreciate that. Moving on to new business, there's not anything on the agenda, but had a couple of things. One of the things I wanted to remind everybody from Gina Solon is that hopefully you've received, and let me know if you haven't, or Gina haven't, Dr. Bassey, who's one of the trauma medical directors in Atlanta, is doing he's in charge of the TMD committee for the state, and he's doing a TMD survey and was asking if you've gotten these, could you please fill them out? It's a very short survey, and they've not had good response from the level 3s and level 4s. And again, this is to get your center in front of and to get your problems as a trauma medical director in front of the committee for the state to see if we can do. And some of the things that are on there are challenges about transfers. So we really want to get those surveys in if we can. So I just wanted to mention that. The other thing we had trying trying to shift through emails here. Sorry.
Thank you, Dr. Patterson. And I'll resend it out to the level 3 and 4 medical directors too. So it'll be up on top of your email list. So you can look for it from me as well, because I have the link. So I'll send it back out today.
Perfect. Okay. All right. And then, sorry, I had one other I'm getting back to here. Is Rachel hand on by chance?
Yes, sir, I am.
Okay, Rachel is the trauma program manager at Wellstar, for those of you who don't know, and LaGrange. And they've been working on a project, hopefully that can help some communications and connect the level 4 and level 3 trauma medical directors with other centers. Believe it or not, one of the things we've done in the past is all the trauma medical directors in the state have a trying to remember what it is. It's a text chain on WhatsApp. That's it, WhatsApp, that we can get to everybody, since it's not affected by some of the cell related issues. So that's one thing we've done in the past. If we had an emergency, we could get in touch with each other. Of course, there's Everbridge in the state that will work without having cell tower function. So I wanted to hear what Rachel and them had on their project they were looking at.
Yes, so thank you for the time to present this and the opportunity to be able to share it. We're really just wanting some feedback. So this is kind of feeding back into your action planning with the Pennsylvania and the ACS focused reviews coming in. So one of the things that came out of those visits was the idea of a mentorship group for the state. Me and Christy Mathis over at Madison, we've been trying to kind of brainstorm and figure out how this is, and Tracy helped us out in kind of brainstorming what we wanted this to look like too. So I do want to give her some credit as well, because she had the initial idea that was presented to us. What we were working on the other day was we basically went through the GCTE contact list, and we isolated the different levels of trauma centers and, put down their TPMs. That's what we were looking at, just isolating those trauma program managers at all these facilities. We broke it down by level, and then we also decided to kind of work through it and see if we could pair them up with an additional level 4 to match their own center level, an additional level 3 and a level 2 or 1 resource that they could then reach out to if they had any questions. Christy, are you on?
I'm here.
Okay. Dr. Patterson, do I have capabilities to share a document?
You're probably, I think you have to share your screen. I'm not sure, to be honest with you.
It looks like Gabby's working some magic, but down the
I got it, I
bottom.
think.
Okay, there you go. Yeah.
There we go.
Yeah.
Okay.
Perfect.
Are y'all
Okay.
able to see this? So
Yes.
Christy, I'm gonna let Christy kind of speak to this document before we go any further.
So we did send out a survey back December, November, to the 3s and 4s, just about, did you want a mentor program? Did you not? So some of the stuff that the feedback that we got was overwhelmingly, we had 14 responses back, and 100% wanted a mentor type program. So some of the comments were assigning mentors regionally. People would like to go and maybe shadow someone, do some mock PIC and M&M reviews, discussing how to manage difficult situations will also help. And then we asked about, you can have kind of a buddy system, and then maybe also once a month meeting on a Zoom where you can just kind of come and bring, like, what I refer to as my dumb questions that maybe I don't want to bring out in, a bigger setting with 1s and 2s, that some of them, they just can't relate to some of the issues that we have. So we kind of put here on this document a list of all the 4s, all the 3s, and then it would kind of move across so she's got me highlighted in orange. This is just kind of an idea, where I would be buddied with Charlie from Effingham. So she and I could be a level 4 buddy. But then I would have someone that I could reach out to at a 3, like Piedmont Walton, and then maybe at a level 1 or 2, we kind of group them together, where I would have a resource at a higher level, and kind of so the 4 of us would kind of all be buddies. But then, I mean, you could, I guess people in bigger, like the Wellstars or the Piedmonts, you're also going to have another connection with people within your hospital system. So I don't know if anybody has any. We just kind of looked at the map, and I know Effingham is not anywhere near me, but I don't really have another 4 that's somewhat close. The other idea or issue that we were talking about is for like Rachel, she and I talk, but her level 4 is nothing like my level 4. So trying to pair up people also that, where I'm putting 50 people in the registry and I need to be paired up with someone and be able to consult with somebody that is similar to me, not somebody who's putting 200 people in the registry a year. So, any ideas?
Yeah, this is definitely open for suggestions to improve it, or ideas that y'all have. Our thinking behind this, as Christy mentioned, was that we didn't like just going back to the level 4s. I am blessed enough to be part of this Wellstar network, so I already have connections with multiple level 4 TPMs that I can reach out to at the drop of a hat without, feeling intimidated about cold calling them and asking them a question. So we were thinking that we would then pair me up with somebody that I wasn't as familiar with, and we were also considering the non-designated centers. So down on the lower end of this, we have our friends over at Tanner who are non-designated but are seeking it out because they have reached out requesting mentors. And I don't think that they are, I might be wrong, but I don't believe that they are as involved in these different committee meetings that are already occurring. They may be attending them, but I don't know that. So we were trying to give them an opportunity to kind of get built into this little web, if you will, of making new connections and reaching out. So again,
Hey,
open for any thoughts.
This is Kelly. I mean, I think this is a fabulous start, because we don't know what we don't know. And so until we try something, we're not gonna know. I mean, I think this is a great idea.
Thanks, Kelly.
This is Dr. Patterson. This is something that is great. This is just grassroots communication, and it is one of my pet peeves when dealing with anyone, residents to other physicians. We've gotten into a society where we just text things or we send emails, and we've lost the personal touch. And this kind of just brings it back a little bit more on a very grassroots level, but it allows you to have this spider web connectivity where you've got a level 4 buddy, or your same level buddy, and then you have your level above or level below, and then even higher as you go up to a level 1 or so, and it brings everybody into face value. I mean, I've said this at meetings before, and I hate to always pick on this because he gives me a hard time, but Dr. Dunn at Savannah was always very intimidating to me to talk to until I realized that he's actually a fantastic guy. He's very easy to talk to. It was just being intimidated by his knowledge base, and he's used that to help me out a tremendous amount. And now we've fostered a very good friendship, and he's become a very good person that I can call if I have a problem. And the same thing with Dr. Ashley. It's been very good to communicate. So I would stress beyond belief to please call people and talk. And then, with the personal meetings that we have, we need to really communicate and get together and really foster these relationships. And I think this would really help us out building a huge network of communication across the state. And I think it's a great, great avenue.
Yeah, this is Gina. I agree. This is fantastic work, you guys. And if I can help, I agree with the whole volume thing, especially with the level 4s. A very small volume level 4 looks very different resource wise from a higher volume level 4. So if I can help in any way, help y'all kind of match up from a volume standpoint, let me know. I'm happy to assist with that.
Yeah, I think that if you're on the call and you have somebody that is somewhat near you, someone you would like to be paired up with, if you can, we wanted to have a meeting in February. Rachel, do you have the date?
Oh,
The
It was
third
the
Wednesday?
third Wednesday in February.
Yeah, and just kind of do a Zoom call or Teams call, and just kind of get it started. But if there's someone that that you'd like to be paired up with, that you're somewhat similar with, or if you could email Rachel or I.
Yeah, February 21st.
Okay.
So what we were thinking was we would have this first meeting in February and have this, what our intention was to send out the invitation to the TPMs at all of the 3s and 4s. So that way anyone who wanted to jump on, it's basically an open call. There's no set agenda. It's, if you have an issue, bring it. If you get an opportunity to talk about it, that's great. The idea behind this is, and I'm going to throw my Wellstar buddies under the bus here for a minute, because we have actually started like a unofficial weekly meeting when we were getting started. And we kind of lovingly called it our therapy session, because we were all new to the role. We were all learning about it and trying to just bounce ideas off of each other, ask questions to other people who understood our pain, and make sure that we were kind of on track with the things that we had to do for the state and whatnot. So it's a way to hold us each accountable. It's a way to kind of get feedback from people who understand your position. So that was our intention behind this upcoming meeting in February. So we will be sending out an invitation to, again, all the TPMs from the 3s and the 4s. It's an open invitation. If someone else needs to hop on, that's fine, if they have any particular questions. And the agenda is just going to kind of go where people take us. So if you have questions, bring it there. It's a trust zone. That's kind of what I want it to be. Open-ended questions are there for people to provide some feedback. We can share ideas, share resources, that type of thing. But it's truly that that buddy system, that grassroots buddy system that Dr. Patterson alluded to. That's exactly what this is. So I think it's just a good basis to kind of start from.
This is Greg again. So would you like the program managers to start emailing you right now about people that they have relationships with, or people that they want to try to, work with before
Absolutely.
the meeting in February?
Yeah, that would be very beneficial, because that will kind of help me finish out this spreadsheet, if you will, and kind of give me an idea of where they want to focus those connections at. So yes, that would be very beneficial. If everybody wants to reach out to me, let me know your thoughts, and I can continue to build this and hopefully re-present it in February, and we'll talk about it then.
That'd be great. That'd be great.
Thank you, Dr. Patterson.
Thank y'all very much. That's very exciting, just about communication. I think sometimes one of the problems with this is that we only meet, every 3 months, and that's not that we need to meet any sooner, but I think it's just sometimes, like you said, you want a therapy session. You want to be able to talk. You want to be able to decompress, and then talk about any problems, or remind somebody about upcoming deadlines or things that you may have forgotten. So this is a very great potential program. I really appreciate it. Any other comments from anybody else?
Yeah, this is Winston. I just wanted to tell Rachel, thank you so much, and her team. The word that you use that resonate really well with me is trust. When you get into the role as program manager, or you're leading the charge, it becomes very, very daunting to you, and it makes it very difficult when you have issues that you want to reach out on, and the first thing that you realize is that, oh, I'm not sure who I can reach out to, because everyone seems to have their own world of problems that's going on. But when you find yourself in a group where you're able to share and care, it makes it so much easier to carry the load. And it also helps you to understand and appreciate the fact that you're not the only one that doesn't know everything. You know, you get to that place where you are more comfortable in going into territory that is new and exploiting those and making the best of it. So I really appreciate this initiative.
Thanks, Winston.
Great. Okay. Anyone else?
Hey, it's Alicia. So yes, I think this is going to be incredibly helpful. And I think it'll be helpful for the TMDs also.
Yeah, I
In
agree.
my opinion, I know Greg and we talk a lot, and I can't say how much I appreciate your wisdom and experience. But I know there's a lot of TMDs at 4s and 3s that maybe don't have that connectivity that we do. And so I think that what Dr. Dassey's doing, trying to revamp the TMD group, will be helpful, and for us to kind of have a subgroup of that, of 3s and 4s, for us to get to know each other as trauma surgeons at these rural facilities. Also, as we go through our ACS verification consults, something that came up with ours was they wanted to see another process than me reviewing my own cases.
Yeah.
They wanted somebody else to be reviewing like secondary review on cases I participated in. Well, I'm 50% of the call pool, so that's going to be a fairly good number of the cases. And I wanted to get y'all's opinions, especially from a TMD standpoint, of would it be more appropriate to ask your partners that are at the same facility, but they're not trauma medical directors, so they don't know how to really do PI from how we do? Or can we utilize this group and maybe your buddy hospital, your buddy program, sorry guys, your buddy program, utilize that TMD and program manager to review your own cases. So I just wanted to get everybody's thoughts on that, because that is something that we're going to have to figure out as they go through and do ACS verification visits.
I with your question, Alicia, I think, you have a very unique situation, and the same thing, I have a similar, unique situation when you're having, they've recommended that you take every one of your cases that's a death or anything that's related to even if it's a consensus case or if it's a clear-cut case or any kind of thing, they've recommended that you take that trauma medical director's case to your PIPS committee, every one of them. And they can't, in other words, you can't review your own cases. And when you're in a smaller center and you've got two people, like you said, your partner's reviewing yours and you're reviewing your partner. So there is technically some degree of a conflict of interest there if they get right down to it. In my case, I've got another group, a competing group that also takes trauma call. And so they're reviewing my cases and I'm reviewing their cases. So you could say that there's a conflict of interest there. So this buddy system may be a way, or either the TMD committee, to be able to have some outside eyes and ears look at your charts without spending an arm and a leg to pay for it. You can get some outside review, but it sometimes costs you a significant amount of money, which is a lot of what we don't have, and we need that for our resources. So that would be a good thing to come out of this as well. And I reiterate your comment, Rachel. You can go ahead and put down that Dr. Register and I are TMD buddies on a level 3 basis. So
Got you.
any other comments? All right, just to let you know, we're for those of you who are new, the project tracking area on the agenda, we do an access to specialty care. And that is annually we do that. We just do an update of all the centers in Georgia with their contact information, if they have a transfer center, what specialty things they may have, like replant or ECMO or anything you may need to refer to a higher level of care. And we usually do that survey and update it in August, and it's usually posted on the GTC website, and usually we give you a QR code for it as well. So we're trying to work on some furthering that project over the next year. So we'll get back to that in August. Any other things anybody wants to talk about? All right, hearing none, I'd move for an adjournment with our next meeting on the 19th of April. Same time.
Motion to adjourn.
All right, motion there. Any opposition? We'll go ahead and adjourn. And remember to sign in with the QR code that's on your screen now. And we appreciate everybody's time this morning. Hope y'all have a great and safe weekend. Appreciate it.
Thanks, Dr. P.
Thank y'all.